It's a pleasure to be here today, and it's a credit to this university that I trained in medicine in a number of years ago. I subsequently went on to work for the World Health Organization in Geneva for 15 years, working on emerging infectious diseases, which was a challenge coming back home to Galway and explaining what you were working on, because it was generally felt this was an issue for Southeast Asia or Africa or low and middle income countries. So what I'm going to do is bring you back to December 2019. And essentially what you have, a situation where this virus is circulating, we don't know where exactly, but it essentially spilled over into human populations. So on the 31st of December, the WHO's China country office picked up a media statement by the Wuhan Health Commission, the Municipal Health Commission, about a number of cases of viral pneumonia in Wuhan. Now, this would have been a common event in Geneva where you would get reports of a reported cluster of cases of an unknown disease. But what was concerning here was that we'd heard nothing from the Chinese authorities. And on the 3rd of January, after requesting more information on this cluster of cases, Chinese officials provided information to WHO that there had indeed been a cluster of cases of viral pneumonia of unknown cause, which were identified in Wuhan. Subsequently, on the 9th of January, WHO reported that China had determined the outbreak was caused by a novel coronavirus. And on the 11th of January, WHO received confirmation that this was a novel virus and the genetic sequence was made available. So it was very rapid once it came to the attention of the world public health community that there was an issue. Going back in terms of the origins of this, we feel that the first known case was thought to be in a female worker in the Hunan seafood market, which is also known as a wet market. And this lady had onset of symptoms, it's reckoned, around the 10th of December. So the evidence suggests a zoonotic spillover event from wildlife species in the market. This novel virus was genetically very similar to coronaviruses isolated from bats and pangolins, but neither was sold in this particular market. It's more common in Guangdong, where SARS-1 originated from in bats. We know that palm civets and raccoon dogs, who historically have been infected with coronaviruses, were sold to the market, but these were not tested for the novel coronavirus. So we basically have an unidentified animal as a likely intermediate host, with bats being the reservoir host. So by the 20th of January, cases were reported from Thailand, from Japan and South Korea, and all of these cases had a history of travel to Wuhan. By the end of January, the first cases were reported in France, in Germany, in Italy and Finland. On the 11th of February, WHO announced that the disease would be called COVID-19. And on the 20th of February, the first case of locally acquired COVID-19 in Italy was reported in a young hospitalized male who had no history of travel to Wuhan. So this was the first incident of community transmission of the disease outside China. In Ireland, the first case was reported on the 29th of February. And that was from, there had been a number of people travelling in northern Italy on ski resorts and brought the infection back into Ireland. We're all familiar then with the footage coming from Bergamo in Lombardy, where the case numbers increased very rapidly, with the ICUs becoming overwhelmed. And that's a scene that was replicated in a number of ICU units subsequently. I know from talking to colleagues in WHO, they said that month of January was very difficult in early February because there was a sense of denial among many European and North American governments, thinking that this was something that would be controlled in China. So it was a real challenge. And our clinicians then on the other side, unsure of what exactly was going to ensue in Europe. So what the study showed, that ventilators became a very important part of the management of COVID patients. In the initial phase, which was the ancestral strain, which was more severe, ventilation was required in about 3.2% of all cases confirmed. The mortality rate of ventilated patients ranged from 30 to 50% in the first 2 waves. And as we all recall, going back to March 2020, there was an increased demand for critical care ventilators across the world. The US government had a stockpile under FEMA of 13,000 ventilators, which Dr. Tony Fauci authorized that they would be released from the strategic national stockpile. But there were challenges with that too, in terms of the usefulness of the ventilators. Then the US Defense Production Act was invoked, which ordered the development of 200,000 ventilators from 11 manufacturers in early March 2020. But a key part of this production of ventilators was the huge problem with shortages of nurses and healthcare professionals trained in the management of mechanically ventilated patients. Medtronic produced 25% of the global supply of high-performance ventilators. Those of you in the ventilator market will know that there are very specific levels. There are home care ventilators, but in terms of critical care and the management of COVID patients and patients with acute respiratory distress syndrome, it is the high-end critical care ventilators that are required. In March 2020, well, that should be 2020, the then CEO Omar Ishrak announced that Medtronic would post the design specifications for the Puritan Bennett 560 ventilator to allow innovators, inventors and academic institutions to look at options for rapid ventilator manufacturing. And Medtronic's Merview manufacturing plant announces the scaling up of ventilator production with an aim to go to 5-fold what the baseline was, operating 24/7 to address the surge in global demand. I'm going to hand over to Tom on the next phase.
Yeah, thanks, Máire. I'm Tom Tuohy. I'm R&D Sustaining Manager at the Respiratory Interventions business, and I'm just going to give a bit of the insight of what it was like during that time. Well, I suppose a little bit before, during, and after the pandemic. So, Medtronic is, I think most people know, it's one of the largest medical device companies in the world, with a revenue of around 35 billion a year and 95,000 employees spread across 150 countries, with 5,000 of those based in Ireland and Dublin, Athlone, but mainly in Galway here, where there's a number of facilities. And Medtronic is divided into a lot of different business units, roughly 20 business units, and respiratory interventions is one of those business units, and it's the business unit that manages the mechanical ventilator portfolio that I work for. But and it's relatively new. Respiratory interventions is relatively new to Medtronic. It was part of the Covidian acquisition in 2015 that we became part of the Medtronic family. And, but prior to that, mechanical ventilators have been manufactured in Galway for over 30 years, since Puritan Bennett set up an operation site in Merview around about 1990. And Puritan Bennett, it's a brand name we still use. Puritan Bennett were the innovators in mechanical ventilation. They developed the first iron ventilator, which was effectively the iron lung during the First World War. They had the first microprocessor-based ventilator, and they set up an operation in Merview around 1990. And that site grew. We grew our capabilities in manufacturing and in engineering support until we became the global site for mechanical ventilators. So within the organisation, and the organisation changed down through the years. Anyone that's familiar with the site in Merview would have seen the name change from Puritan Bennett to Nelcor Puritan Bennett to Mallinckrodt Nelcor Puritan Bennett to Tyco Healthcare, and on to Covidian before we were acquired by Medtronic. And I think, when you hear of Medtronic, everyone knows about Medtronic in Galway, and they all think cardiovascular. Very, very few people would have known that ventilators were manufactured in Galway. Yet every ventilator that is manufactured by Medtronic, and as Máire showed there in the slide, that's roughly 25% of the global supply. Every single ventilator is manufactured in that facility in Galway. And just to give a kind of context, it's a relatively mechanical ventilation has been a relatively stable business. While the ventilators are quite complex electromechanical devices and have a lot of technology in them, the technology hasn't changed that much down through the years, and when someone buys a ventilator in a hospital, it typically is installed and sits there for 10 years and is used for 10 years. So it's been a very, very stable, steady demand, and we would have been producing about roughly 10,000 ventilators per year, and the workforce in that plant is just less than 400, maybe 200 directly involved in the building of ventilators, and another 200 in the support functions, engineering, finance, quality, and so on. So when the pandemic struck, then, you know, suddenly we went from being, you know, a small part of, you know, roughly we would have been about 1% of Medtronic's business overall, you know, with 200 people building ventilators, and suddenly COVID came and everyone wanted a ventilator, and there was huge demand. So, like, we had one region putting in an order for 100,000 ventilators. You know, there was the US were looking for 200,000 ventilators. We were producing 10,000 ventilators a year, and I don't know if you remember back, but there was lots of different news features saying how to build a ventilator, who was going to build them, demanding them. There was 200 people in Galway trained to build ventilators that were servicing 25% of the global demand, and suddenly everyone wanted it. So we were faced with an almost impossible task, but you know, I suppose we were asked, you know, when the rest of the country was shutting down and places were closing and people were going home, we were being asked to you know, meet all this demand. But we set about it, and I suppose you know, there was 4 kind of key pillars to what we had to do, you know. So we had to look at, you know, the people in the facility. So we had to go from, you know, we had to set kind of realistic targets. So we looked at our floor space. We got additional floor space from other Medtronic sites. We doubled our workforce. We doubled our floor space. We got other Medtronic sites to come on board to provide us with some facilities. We went to a 24/7 operation. You know, it was a lot of work and training employees, and that was key to what we did. The other thing then is we partnered with you know, with different industry. We worked with companies like SpaceX who were offering us help, and they helped us build PSAW, which is a key component in our ventilator. We worked with companies like Baylis in Canada who wanted to build ventilators themselves, and we open sourced the 560 design, PB560 design, one of our ventilators, and they were able to do that. We worked with other companies you know, across Asia to do likewise. You know, we worked locally with Celestica to get additional floor space. We had to work with our suppliers then, because, as I said, the ventilators are complex devices. You know, there's over 2,000 components that we buy from over 300 suppliers, so we had to work very closely with our suppliers. Our suppliers were facing the same challenges as us, you know, with the workforce and so on, and different, you know, we get components from all over the world, so we had to work with them to provide them with both technical support to help qualify alternate materials, with some of our smaller suppliers to invest to help them invest in getting some capital equipment, and that was needed to meet the demand. And I suppose finally then the final part came down to execution and delivery, and you know, key to that was having realistic targets. You know, there was some panic buying going on, and you know, crazy numbers come in, but we set realistic targets over the first couple of months. You know, our goal was what we called a drive for 5, to go from building 200 ventilators a week to building 1,000 ventilators a week. And you know, we really worked closely with our employees, got great engagement. You know, there was 2 key pillars: safety and quality. You know, we made sure, as we were bringing people in, you know, we had all the precautions in place, the mask, the hand washing, you know, before we got that in place immediately. The social distancing, we replicated lines. You know, on a production cell, people are standing close together. We put in the equipment so they could be spaced out and have that. And you know, fortunately that paid off, and we had no outbreak. And the other thing was quality, product quality. There was no shortcuts taken, even though the pressure was on, the time was on. We took no shortcuts with quality. You know, we brought in additional quality people. You know, we looked at the efficiencies and what we could achieve through efficiencies, but we never sacrificed the product quality, and subsequently, again, that paid off, because we had, with anything that was built during that time, there was no we didn't experience any you know, additional increase in complaints. So it worked. We were able to, you know, there was that peak crazy panic buying that kind of settled down into a manageable level, and we reached our goal of going to 1,000 ventilators a week. So it was a very, very exhilarating time, a very scary time, as I said. That when you think about it, you know, as the news reports were all going over President Trump, you know, calling for more ventilators and demanding them, and you know, getting Medtronic to do it, and when really there was about 200 people in our production plant in Galway that were trained to do it. So you know, we had to go from there. Then, you know, things have kind of got back to normal again now. We're back to what the pre-pandemic demand. We're building, you know, roughly 200 a week again, ventilators. You know, we've got a lot of really good partnerships in place. We've learned a lot. We've, you know, we've efficiencies that we're taking forward. But you know, we've kind of gone back to normal, and you know, that's. You know, we all want to move on. No one likes talking about COVID anymore in those years, but it's really, really important that we learn lessons from it, and that we share that experience, you know, with the wider community as well. So as Máire will talk a little bit about the collaboration program, that's really what it's looking to do, to take the time to really reflect on the lessons. You know, we did, as I said, a lot went really well, but, you know, we made some decisions and some of them didn't pay off. Some of our collaborations didn't always pay off, and, you know, we on some of our suppliers, we over forecast, and, you know, so the project, the VENPREP program, the research program, will help us take the time to